we move on to the next session. First of all, I request Dr. Lakshmi Dadi ma'am and Dr. Bhavya. Dr. Anand ma'am, we all know she is consultant critical care at Care Hospitals Vizag. And Dr. Bhavya, she is consultant critical care at King's Hospitals Vizag to kindly chair the next session. There are two lectures in this session. The first is going to be by Dr. J. Srinivas.
Thank you, Dr. Lakshmi, and I thank Mohan sir and his team for having me here. And today topic is on hematological parameters and outcomes in sepsis. Basically, there is no company funding; it's an unbiased talk because this capability is present only for the few machines, and it's a purely academic. And in sepsis, early diagnosis and treatment reduces mortality. The ideal biomarker, which has to be validated, inexpensive, and widely accessible and rapidly available results. We have approximately 118 biomarkers in sepsis, but most commonly we use CRP, which is approximately around 500 in my hospital, and procalcitonin is 6,000 rupees in my hospital. So biomarkers in sepsis, we need to have identifying or ruling out sepsis, evaluating the severity and assessing the prognosis, and evaluating patient's response to treatment. So in this diagram, as Dr. Pradip sir has mentioned, so we have inflammation. We do nowadays we are doing interleukin 6, IL-6, and these causes. One is through the liver, the CRP is elevated. Another one through the parenchymal tissues, procalcitonin is elevated. And here, if you in the middle, there is activation of the neutrophils and monocytes and activator. If you see into the bone marrow hematopoietic stem cells, so we have one side is the lymphoid progenitors, another side is the myeloid progenitors. So in this, we look into the erythrocytes and then basophils, which are very less in quantity, is difficult to analyze it, and the neutrophils and monocytes we look into it. And surviving sepsis guidelines, as mentioned, for starting an antibiotic, they don't use procalcitonin, only compared to clinical evaluation. And when discontinuing antibiotics, they can use a procalcitonin with the clinical evaluation. It's a weak recommendation. So let's first look into the erythrocyte. So red cell distribution width and hospital mortality in patients with sepsis is published this year. So it is not the red cell distribution width, it is the red cell distribution width. It is not the red cell width. So when the patient is having an inflammation, the cells change its morphology and it's distributed wide. So red cell is changed in many of the conditions. So what happens? The distribution width, if you see into when there is a low, it is normal value is less than 12. If it is low anisocytosis, it is seen in 12.6, and it is high, it is 16. So it can go high also in a patients. So this is data from almost 10,000 patients from 177 hospitals. They have taken a normal red cell distribution width as 14.5, high as more than 14.5. They found that they done a logistic regression analysis. They found that there are three factors which impact mortality. The model one, they have taken the patients who they got a full data, and some of the patients they did not get a data where some of the characteristic features. So they have again analyzed into the model 2. So model 1 or model 2, when there was only three factors which predicted the mortality is red cell distribution width, SOFA, increase in SOFA and Apache. So here, the area under the curve, the RDW is 0.631, it's less than SOFA and Apache, but it's almost comparable to that. So here again they analyze the sepsis into different types of either cutaneous, GI or other pulmonary, urinary and unknown causes. They found that again in these all conditions, the only three factors like RDW, SOFA and Apache 4 has proven to be in the associated with the mortality. They also looked into the as from the prognostic factor and its comparison with the lactate in sepsis. This is a patient large data, one of the like around 500 patients they are taken, and which were admitted due to sepsis. They looked into this data and they found that there is, for the cutoff point of 14.5%, the patients who is having a high RDW has a high intensive care unit admission, and they were more in septic shock, and 30-day mortality in the hospital is very high. They could not find any difference in a patient who is endocrinically intubated and acutely intubated patients. So again, they have done a univariate and multivariate logistic regression models, and they found that again there are only 3 factors which increase the mortality so far: RDW and lactate. And coming to the next factor, early granulocyte count. These are seen only in the neonates. If you find immature granulocytes in the patients with the bone found in the blood smear, that is abnormal. It can be infection or myelodysplastic syndrome or proliferative disorders. So this comes under this group. So EGCR is also called as immature granulocyte index. Here, they have taken all the sepsis patients. They are analyzed into 2 categories. One is culture sepsis, and another is clinical features of sepsis. So when it is only culture sepsis, the first category, culture is negative, sepsis is negative, clinical findings. They found that Ig percentage of less than 2, that is the normal, is around 95%, 91%, and culture sepsis both are negative is 8.9%. And the culture is negative, sepsis is positive. They found 64 and 35. The culture is positive and sepsis is negative. It is 88 and 11. So culture is positive, sepsis is positive. They found 46% and 53% respectively. So it is in a patient who is having a culture and sepsis both as negative. It is Ig percentage less than 2, almost it predicts 91% that this patient doesn't have a sepsis and difficult to grow a culture. So here is sensitivity with the blood culture, or it's a clinical information. Sensitivity is 75% in a blood culture and 45% specificity. And there is a clinical information confirmation, it's 69% in sensitivity and specificity is 29%. So they also have looked into the percentage increase, like whether it's Ig percentage is 2, 3 and 5. And then they have looked into the sensitivity and specificity. As the sensitivity is decreasing, as the percentage of Ig percentage is increasing, the specificity also is increasing, but is not increasing much. So that's the reason why if a patient immature granulocyte percentage is 2%, we can say that the specificity is almost high in these patients. So the similar thing, because another delta neutrophil index, another type of different machine, almost measure the immature granulocytes. Here also they have looked into the few patients. Here they have looked into the patient with sepsis, septic shock, and DIC and over DIC. And these they compared with the WBC, neutrophil count, and the delta neutrophil index, lactate, and CRP. When they found with sepsis and septic shock and with sepsis and septic shock, the 3 parameters which have shown significant is delta neutrophil index, lactate, and CRP. When they have compared with over DIC or without DIC, they found only 2 factors. One is delta neutrophil index and lactate. So delta neutrophil index is one of the good indicator in diagnosing the sepsis and also prognostication of these patients. So in the performance of delta neutrophil index, they also has looked into the variables and its sensitivity and specificity. It has a good sensitivity. DNA is having good sensitivity of 81% and specificity of 91%. So when compared with the WBC, ANC is better, and almost compared to the CRP also it is better, this index. So next, we'll go to the monocyte distribution width in early sepsis. So they had taken almost 2000 plus patients into the sepsis 2, sepsis 3 criteria, and they have looked into the parameters. They found that MDW more than 20 is sensitivity is 74%, specificity is almost 72%. And they have looked into the WBC, tachycardia, body temperature, tachypnea, hypotension, and after mental stages. So these are almost like abnormal WBC. Tachycardia is almost similar to the MDW, and more specificity is present for the tachypnea and body temperature in this study. And they have interestingly they looked into the WBC. So most common thing when the patient is having the sepsis, we look into the WBC. When the patient is having a normal WBC, the total of patients of 120 patients having sepsis, in this normal WBC, the abnormal MDW is present in 89 patients, and MDW normal is present in 31 patients. In a patient who is having abnormal WBC, the normal MDW is present in 69 and abnormal in 196 patients. So it consistently, the MDW is more than 20, consistently increases sepsis probability, and MDW normal reduces the sepsis probability. So when combined with in the regardless of cells and Q so far, this has MDW has increased the initial ED encounter with associated with increase fourfold increase in the odds of sepsis 3. So monocyte distribution width in compared with CRP and procalcitonin. So they have grouped into three type of patients. One is non-infection, the infection, and again the sepsis patients. They said that patients having an infection with a high SOFA. So they found that the patients with the biomarker levels, whether CRP, PCT, WBC, or MDW, these all, when compared with the non-infection, infection sepsis, all are significant, and levels has increased. You were able to differentiate these patients. When again they have divided into immunocompromised and immunocompetent patients. When they have divided into immunocompromised and competent patients, the MDW, CRP, and PCT is almost like a good, the AUC almost 0.6 to 0.7. In an immunocompetent patient, also MDW, CRP, and PCT almost is a similar AUC, 95%. So importance of mean neutrophilic volume. So this also similarly they have taken almost 148 patients, non-sepsis, sepsis patients. In that they have taken gram-positive, gram-negative infections, and they found that there is no difference in the CRP and WBC in a patient who is having a gram-negative or positive infection. There is a difference when there is a non-sepsis and sepsis, but clearly MLV could differentiate between the number is very high in patients with gram-negative infection. So it has a sensitivity of 79.3 and specificity of 61.7. So we all know that COVID we have managed and we have looked neutrophil to lymphocyte ratio, and now into the sepsis. This is a prospective trial. Adult patients with sepsis are admitted to ICU for 2 years period, 333 patients, consecutive patients. Here the univariate odds ratio of unfavorable outcome were significant in patients with Apache 2 scores and in a patient with NLR ratio and also its increased age. So when they have looked into a multivariate logistic regression analysis, Apache 2, NLR and age has increased, increase of these values has increased the mortality. Indicators with disease severity, Apache 2, neutrophil, lymphocyte and NL ratio has increased the mortality, in the increase in the like a sepsis, severe sepsis and septic shock as the severity increases, these ratios also or the numbers have increased. So from this, actually by doing this one, it doesn't need any specific test. You discuss with the pathologist. There are machines with the CBB machines with software. You can analyze, discuss with the pathologist, and you get all the values. We have approximately enrolled around 200 patients. We are collecting the data on these parameters, and we have not analyzed. Hope we all do this. So data collection and look into a good analysis. I think we don't need to have a daily. Most of the times in the ICUs we do CBC. either daily basis or alternate or every 3 days. So if we do a better analysis and better results, I think we don't need to go for other parameters, and we can even save the lives of the patients, and at the same time we can save cost to the patients. So hematological parameters are very important. We have to need to look into all these parameters. We need large data to validate. Thank you.
Sir, can you show a light on this platelet and lymphocyte ratio regarding this platelet lymphocyte distribution with ratio?
These are lymphocyte. Basically, platelets, we are looking at the data, platelets. Looked into the data on platelets, but platelets usually they are not easily, like there is no major changes in the platelets immediately when there is a sepsis or severe sepsis as per the old definition. So it is also decreasing. Its value also is decreasing, and only in severe conditions.
Only thrombocytopenia?
Yeah, thrombocytopenia. Yes.
Any difference in gram positive and gram negative, sir, regarding this hematological?
The hematological only MNV has shown, but there is no clear data much on this because it's also an inflammatory markers. So whenever they are collecting the data, they are collecting most of the patients on retrospective data, and if they are doing a prospective studies, they are doing hardly around 100 or 150 patients. So I think we need to have large data on this, but we can clearly see the differences once you start looking into all this.
Okay, sir. Thank you, sir.